And welcome everyone to episode number 24 of our NCAA social series. I'm Andy Katz. Pleased to be joined by the NCAA's Chief Medical Officer, Dr. Brian Hainline, who's been with me from the beginning here of this pandemic. And pleased to rejoined by Dr. Colleen Kraft from Emory University, Associate Chief Medical Officer at Emory, and also part of the NCAA's Coronavirus Advisory Board. And Dr. Kraft, I want to start with you. You were on with us early on. I think a lot of us thought we would be in a different place at the beginning of September. Not that you have this answer, but I'm going to ask you anyway. Why are we still in a very chaotic place here at the beginning of September?
I think our guidance really overall has been chaotic from a federal level. I think it's been confusing. I think it's something that I, as somebody that had been preparing for pandemics for much of 6 years after Ebola, thinking about a respiratory pandemic, you know, the thought of the public not actually wanting to abide by public health recommendations was not something on my radar. And I also thought in March, or actually in February, when we started meeting and I was invited to join discussions with Dr. Hainline, I really thought that we could be talking about fall sports, that we would be returning to sort of a normal and like a real normal. And so I think that the lack of you know, universal mask mandates and different things like that have led to us really being in a position where we're still seeing a lot of waves and surges all over the United States.
So Dr. Hainline, there are basically two schools of thought here. You know, you can make the argument in this politically charged country right now, we live in two countries almost, and within athletics, it's almost like we are in two different countries. The SEC, the ACC, the Big 12, they're planning on playing college football. We've already seen college football start within the last 2 weeks. The Big 10, the Pac-12, the MAC, the Mountain West, and others have chosen not to and not play any fall sports. Why are there two schools of thought within Division I?
Well, I think, Andy, with a lot of emerging disease conditions, or even those that are not, people can look at the same data and come out with different sorts of ways to handle a situation. I mean, in my profession of neurology, that happens all the time. Surgery, not surgery, wait, don't wait. In this case, I think one thing that's very important to stress is that with all of the football schools that are considering to play, they are looking at the same core recommendations that those that chose not to play. And there's a document in the Autonomy 5 Medical Advisory Group with the NCAA panel. We are 100% unified. And we gave the 5 reasons for discontinuing sports. So those haven't changed. But what the SEC and the ACC and the Big 12 have and others have said, well, they're looking at that and saying, well, maybe we don't need to make a decision right now. Let's ride this out a little bit and see if the circumstances change. And so what we have seen is that the circumstances have started to change. One thing is that the infection rates have leveled off. They're still not where we would like them to be, but they're not increasing dramatically. And the other thing that's shifting is testing. So the testing paradigms are changing, and that may allow us to make different sorts of decisions. And so, you know, the other important thing is that, you know, the Big Ten decision, well, this was made by Big Ten presidents and chancellors, and they look at that data, and the same thing with the Pac-12. So it's not football coaches making the decisions, it's not athletic directors, it's the presidents and chancellors of the university, and they're making informed decisions. And so that's very often what happens in medicine and in society at large.
We're going to get to testing here momentarily. Dr. Kraft, you know, you're not at an SEC school, but you're in the heart of SEC country in Atlanta. To Dr. Hainline's point, how much of this is more about risk tolerance versus disputing actual facts that are being provided by this panel and all the other medical experts around the country?
Well, I think that Dr. Hainline said this very well, that people can look at the same information and want to try different things and try different solutions. And so, you know, there's a lot of prevailing ideas that young people, younger people are less at risk of having severe disease in sort of a mortality, morbidity statistic standpoint. So if you're looking at sort of different outcomes, you might say, well, I'm okay with it because it's not going to cause X, Y, Z. And so I think that, that's really one of the reasons that we're sort of seeing these different pathways. I think one of the things, though, unfortunately, that this virus is teaching us is that we can choose our pathway, but it's still going to behave in the way that it behaves in every state and every city across the United States. So I think that, we're getting a lot of immediate feedback, or I would say it usually takes about a month to see if you're the way that you have planned and are trying to contain the virus is actually going to work. You get feedback by the number of cases that you end up with.
Dr. Hainline.
Well, Andy, I just want to go back on your question originally too to Dr. Kraft and about possible denial of facts versus looking at things differently. The one thing I want everyone to understand, so I've worked very closely with the SEC, the Big 12, the ACC, and really all of the Autonomy 5 conferences. They all have medical advisory groups, and these are all exceptional individuals. These are physicians and scientists that really want to make the right decisions. And what's interesting is that they were all part of a cohesive group, the Autonomy 5 Medical Advisory Group. And their decisions in terms of, the final recommendations were exactly aligned with the NCAA decision. So I'm really highly confident that from the decision-making point of view, with regard to football, no one's denying any facts. Again, it's look highly respected individuals that are looking at the data, and yeah, some of it's what you take a risk if you do this, and you take a risk if you don't do that, and so the sort of tolerance you have, and again, playing it out, and I think Dr. Kraft said it best. Ultimately, yeah, the virus is going to decide, but meanwhile, we do the best we can, in terms of assessing the data.
Well, and that's the thing, and it drives me crazy. And I got to just say this, that, for those that love to critique and say that not all the information was provided and, different conferences didn't have the same information. We've been doing this program for 5 months. We've been issuing this information. And if you've been paying attention, the information is out there. It's just like whatever issue you have personally, you may get a second opinion. One doctor, as you said, Dr. Hainline, may say, have surgery. The other one may say, no, try PT. So it's the exact same thing. And that's one last topic before we get to testing, is on myocarditis. That's now a hot topic. One set of medical advisors will say, no, it's too high a risk. Others have said, we're not seeing it. Dr. Kraft, Dr. Hainline, if you can comment on that as another issue where it's one fact and two different opinions on whether or not it affects young athletes.
Right, so I'll talk about it from sort of a global level. I think I've been quoted before maybe on this program and saying that one case is too many for myocarditis. But then when we think about sort of this risk tolerance that you sort of suggested earlier, which is how important is it to have people engage in something that's really important to them, these universities, the region, the United States, and there are lots of decisions we make. We don't think about influenza infection very much, or the consequences of influenza infection, because we don't have a lot of close personal experience about it if we're not in healthcare. And so I think it's really hard to know. I think even a risk of one is concerning to me as an individual provider. I think when we think about it over, as something that's evolving and that we're discovering. We just had an individual admitted to our hospital recently that had myocarditis, not an athlete.
Everyone should know it's a heart condition. Right?
Yes, thank you. It's the inflammation of your heart. We're still trying to understand if it's directly from the virus or if it's the inflammatory state that the virus creates in your body that then leads to your heart muscle being damaged. And I think that it's really hard to know, we're continuing to describe a phenomenon as this virus is progressing through our society. And so it's really hard to know if we exposed, we'll know in a year if we expose 100,000 people to this, we get one case of myocarditis. It's a lot easier to make decisions about athletes and different things as you have the benefit of hindsight. But we don't have that benefit yet. And so as we're progressing forward, we're trying to balance all of this data sort of at the same time. We're building the car as we're driving it.
Yeah, and to take it one step further, so we updated our guidance as we're learning more about this, but I think it's important for everyone to know that, we've been talking about myocarditis with viral syndromes in sports medicine for over 30 years. We know that any symptomatic viral syndrome, and we never really talked about asymptomatic viral syndromes, can cause a myocarditis, and we always cautioned our athletes against exercise when they had a symptomatic viral syndrome because of myocarditis, so this inflammation of the muscle of the heart. But we are seeing this highly scrutinizing COVID more than we ever saw for any other viral syndrome, and the guidance now is, if you've had a COVID, that to return to sport, it includes getting an electrocardiogram and a blood test called a troponin, which looks at possible damage to the heart muscle, and an echocardiogram, which is a sound wave test to see if there are pockets of fluid and so forth. And so, it's taking it one step further. And I think as well, the other important thing I should say is that in conjunction with two important medical organizations, we're actually starting a cardiac registry. And so that has begun, and so we're following individuals prospectively. So I think the possible interaction between the coronavirus that causes COVID-19 and myocarditis is going to be the best studied interaction in the history of viral syndromes, because it really is getting exceptional scrutiny.
All right, so now we got to shift to testing. That's the elephant in the room here. I've heard Dr. Scott Gottlieb, a former member of the Obama administration, talking about how we're getting closer to that test that could be like a pregnancy test, which obviously could change the landscape of everything. We've got the saliva test out of Yale that the NBA was using and pushing with the NBA and the NBAPA. Illinois, you could debate how successful they are right now, but they're using something similar to that they're doing on their campus. So is Georgia Tech, near you, Dr. Kraft. So Dr. Hainline, then Dr. Kraft, where are we in testing in terms of getting to the point where it's a rapid test, not the same rapid we've had before, but the rapid test that would allow for quicker, return to sport, and allowing these teams and these players to practice and knowing who has it, who doesn't, just on a much more every couple days, weekly basis?
So I think we're getting close, Andy. We've been speaking about this for months, and really the necessity to get rapid diagnostic testing to move sport forward. So just a couple of things. So Saliva Direct. So that's, you mentioned University of Illinois, and that really is what was developed by the NBA in conjunction with Yale University. It doesn't require the same reagent to do the PCR test for the virus. It's not a point of care test, meaning it's not something that you do with a machine right in your office. But what University of Illinois did is they converted their veterinary lab into a large testing laboratory, and they're able to process 10,000 tests a day for Saliva Direct. They're able to test their football team on a daily basis. They've looked at the sensitivity of Saliva Direct, and it's probably around 94%. And so that's not perfect, but if you're testing someone on a very regular basis, you don't need a sensitivity of 100%, because the mathematical odds of the same person testing negative 2 days, 3 days in a row is quite improbable. And then the other tests that are emerging are the point of care tests. So point of care antigen tests. So that means that you're looking at a protein of the virus, and even point of care PCR tests. And when those are really widely available and you can get the results within minutes, and it's, for $5 a pop or something like that, that's going to be a game changer. But Dr. Kraft is much more an expert on testing than I am, and has been at the front lines and working with Emory's lab.
Yeah, I mean, I think you really summarized it well. And I was going to say, if this is the elephant in the room, I've been living with this elephant for a long time. So we have been thinking about, I think and breathe and eat and live testing for COVID-19. And I think that I did also think, much like we would be talking about fall sports in September, I also thought we would be having very routine tests already developed by now. And so there are a number of initiatives that you've already mentioned. There's the point of care tests, the Saliva Direct, which is still a PCR test and maybe really isn't considered rapid, although I think University of Illinois has managed to automate it so that we can get it sooner. And there's also the evolution of knowledge about how you can use rapid testing or lower sensitive testing in asymptomatic or low prevalence populations. And I think that that's what I've grown as a laboratorian who's very interested in the best test for each patient. You know, we don't want to compromise on our sensitivity and specificity. What we've learned during this outbreak is that you are very likely in a low prevalence population to not really have any misses that are going to be cause widespread transmission or that are going to cause very serious illness. And so also the frequency of testing helps support that maybe lower sensitivity test that Dr. Hainline was discussing. And so I think that, you know, I've grown as a clinical laboratorian to sort of a wider spread idea of public health and, sort of balancing, a rapid test for a sensitive test, but that being okay if there's repeated testing that's involved.
All right, so not to put you on the spot here, Dr. Kraft, but how soon do you think we're going to see this kind of testing widespread in the public space, especially on these university campuses?
Well, you're not putting me on the spot because I get asked this every day. Okay. And so and it changes every day. I always say every time I give a lecture on any of these things, like I actually gave a lecture on Saliva Direct for individuals on when you hear about these things in the news, how you actually evaluate what type of test it is. Because there's always a lot of press about how amazing this is going to be and how much of a game changer it's going to be. But actually digging into the details, you have to realize sort of the limitations and benefits of each test. We're also involved at Emory in the RADx program that's funded by NIH, where we're actually kind of being the test kitchen for some of these even preclinical assays for COVID. The whole crux of all this is going to be supply chain. And I know that's a very ungratifying answer, but there are so many great tests out there. We just can't get them manufactured quick enough. And so, my hope was that the manufacturing stream was going to pick up. NIH has been investing through this RADx program and giving individuals that have very good tests that they have in the preclinical realm, that they're investing in them to basically help them operationalize their supply chain. But that is really what it's going to come down to. So if you want sort of a when this is going to happen, I mean, I would have thought it would have happened by now. But I think I'm hopeful if there's a late peak in the flu season that maybe we'd be able to meet it with the rapid testing. So I'm going to say, for the record, and in 1 month you can come back, or 3 months, but I would say February.
I'm sorry, say again?
I'm going to say February 2021.
Is when this is widespread?
Yep.
Okay. One other aspect of this, this testing as a university is at Arizona. I've seen that they've done wastewater.
Yes.
How prevalent is that on these campuses to sort of snuff out potential outbreaks?
Yeah, so it's a really indirect measure. My dad was actually the manager of a wastewater treatment facility, so I have intimate knowledge of what this actually means.
Those must have been interesting conversations.
Yes. He studied, he worked with poop. I worked with poop and fecal transplants, so it comes for full circle. Yeah. So, I think it's a great idea. I love all these ideas. I love the, how innovative we're trying to be, but it's really hard to kind of indirectly measure this. The solution to is dilution, right? When you think about wastewater. And so there's always sort of this balance of like how much more of one thing than the other. I think it's a compelling way to indirectly find things, but I think it's a hard thing to keep measuring. I think going back to the individual is probably going to be the most reassuring aspect.
Right.
But certainly like intermittent testing of wastewater could make sense. But right now with the prevalence being so high in some areas, I mean, it's probably always going to be positive.
All right, so I want to take what Dr. Kraft just said a moment ago, Dr. Hainline, about February 2021. Everyone's all obviously excited about a potential vaccine. I want to take the politics out of it. I'm not going to think about it before November 3rd. But February 21 of this being widespread of a rapid test of this nature versus the timeline of when potentially we could have a vaccine in our arm, not necessarily one that's approved by the FDA. Which one potentially could come first?
Well, I think we have to actually not accept either of those options because we need an option really moving in September, October. As we're rolling out basketball and we're moving into indoor sports, we can't wait for the vaccine issue and we can't wait for when everyone is going to have these rapid diagnostic tests. So that's why we're, there still are, like with some of the antigen point of care tests, they're not going to be widespread from a public health point of view, but I think they will be much more widespread available at the campus level. So that's one thing we're going to have to work with. And I think saliva direct, as we get more and more labs that can do this, or as we become innovative like University of Illinois did, or I think there's probably even going to be mobile units that could use the technology that, say, University of Illinois used. So there's a lot of possibilities between now and, say, February. And so even, let's say there's a vaccine, let's just say that it is tested by the end of this year. It takes a long time to really measure the effectiveness and to get that rolled out into the general population. So you're still looking into the summer of 2021. So I don't think we can wait for either. We're going to have to still move quickly with what we have and mobilize that.
So a couple of very quick points here I just want to get your thoughts on. I want to just go back to Illinois real quick that I think was fascinating is the technological aspect of the test, which is they have an app at Illinois that says whether or not you're positive or negative before you can enter a building, before you could enter the locker room, the court. How much do we need to get to that point where we all have that kind of access? And look, I know civil liberties people and libertarians may come after me on this, but we need to know who's positive, who's negative. If someone near you is this, and I know this has been working in Southeast Asia, but this is happening in Illinois where they have an app. I mean, how much, Dr. Kraft, do we need something like this to know who's positive and who's negative before we even go into an arena, into a classroom?
Yeah, so I think it's going to be really important if we want to try to move the needle to get to the new normal, right? So I think that, like Dr. Hainline just said, we can't wait for everything to sort of line up. If we want to try to get things sooner, we need to kind of be creative, and this is a way to be creative. I think one of the things that concerns me and what we see in the hospital is we need to make sure that it makes clinical sense as well, because I could have been positive, a month ago. Well, that shouldn't still flag as positive. So I think there's going to have to be some clinical informatics decision making.
Well, I think it has to work. Yeah, I think it has to work with a rapid test.
Yes.
Yeah, you couldn't have had a test like a month ago and have that still on your app.
Right.
But you think they have to work hand in hand?
They definitely do, but I'm saying that just from implementing this in our healthcare system, it sounds very binary and very straightforward, but there's lots of opportunities for glitches. And so I don't want to get too operational and detailed in this type of setting, but I think it's definitely where we need to be. I think, for us, it's temperature screening and a sticker that we wear every day in our healthcare system. I do think sort of there's a reassurance aspect, but there's also a responsibility aspect that comes with that.
All right, last thing I want to get to here is what you just brought up, Dr. Hainline. So men's and women's basketball, the plan is more than likely, we'll find out in a couple of weeks from the Division I Council, there's going to be a new date for the start of the season. The start of the season is supposed to be November 10th. It could be November 25th, could be the first week in December. They could push to Jan 1, but more likely it's going to be somewhere in that Thanksgiving time period. But they're doing that with the anticipation that we'll be able to play, whether that's in mini bubbles on campuses or neutral sites. But the anticipation is to play. And we have to weigh, obviously, the balance of there was no tournament last spring. There was no college football for the majority of conferences. People are getting furloughed and laid off, and the economics are just crushing right now at universities. So there needs to be a season. So how do you balance? They're going to make an announcement when the season should start. And how do you make sure that it's safe and healthy at that time of the year when we don't know what the flu season is going to look like and where this virus is going to be around Thanksgiving?
Yeah, and the question really should be expanded beyond infectious disease as well. So there were really important deliberations and deciding when the season should be. And one of the really important reasons for suggesting a delay, of course, the council is going to, ultimately weigh in on this, is just the periodization and acclimatization of these athletes. I mean, are they really ready to begin play on November 10th? And so part of it was allowing them more time to train. So when we talk about sport, we talk about the state of optimal readiness, and that's a physiological state. That's both mental and physical. And these athletes, our student athletes, are not in a state of optimal readiness. They're not in the right physical shape. We know that the mental health symptoms and disorders are increased relative to baseline. So we have to address all of that before getting into a full season, while simultaneously saying, look, the current testing paradigm of once a week just doesn't make sense, especially when you move into basketball and you're moving indoors, and there's really sustained close contact that is different than in football. So the safety is both physiological and infectious disease, and that's being worked out. I mean, there's a lot of really careful thought about that, but it's going to have to be both. We have to solve both.
Dr. Kraft?
What was the question again?
Well, just the fact that all these things are weighing heavy, and there's going to be a decision on the start of the season. We don't know where the virus is going to be. We don't know what flu season will be like, and whether or not it'll be that bad if we're not really next to each other a lot and we're wearing masks. But at the same time, there's going to have to be planning. And so if they make an announcement that the season's going to start around Thanksgiving, you're going to have to balance, okay, if we're going to do this, health and safety, but we got to make plans for it over the next 8 weeks. So how do you do that?
Right. I mean, I think this is what we've been doing since March, to be honest. I think that we have, done our best to sort of watch what we've done, to see what the results of our actions are, and then try to build a comfort level around implementing this sport. I think, it's like we've already said, it's really important economically. It's really important for the athletes, the universities. And so I think that, it's what needs to happen in order for us to try to take a step in the direction of playing sports. But there's a lot that goes into it, and it seems like every kind of place we turn, there's sort of a new challenge, a new obstacle, a new deadline that we try to work with and try to innovate and be creative around in order to sort of have something happen again.
Well, the bottom line is obviously we're going to get to a point where we have to plan. And if things change, they change. I mean, we've already sort of learned to adapt and go with the flow and be flexible, obviously, since March. Dr. Kraft from Emory University, from the NCAA Coronavirus Advisory Panel, appreciate it. This is your second time on the show. We want you back anytime you can come on, obviously, with your incredible knowledge on the subject. Dr. Brian Hainline, appreciate you as always. This is episode 24. If you want to look at the previous 23 episodes, go to ncaa.org/social series. They are all archived. And as I've said throughout this show, we've been talking about this. So you cannot say that the views and the information has not been out there to advise these universities, these athletic departments, these coaches, and these players. It's been right here every week. Appreciate you all. Stay safe, and we'll talk again next week.